This video is an introduction to the diagnosis of acute rheumatic fever. Information is derived from the 2020 Australian Guideline for Prevention, Diagnosis and Management of Acute Rheumatic Fever and Rheumatic Heart Disease, 3rd edition. The learning objectives are to recognise signs and symptoms of acute rheumatic fever and identify the required actions for suspected acute rheumatic fever. Acute rheumatic fever, or ARF, is an illness caused by an autoimmune reaction to infection with group A streptococcus. It causes a generalised inflammatory response which can affect the heart, joints, brain and skin. It can be very painful and requires referral to a specialist and hospitalisation. The damage to the heart valves caused by ARF is called Rheumatic Heart Disease, or RHD. ARF is most common in the 5 to 14 age group, but can occur in people aged into their 40s. ARF and RHD are notifiable diseases in New South Wales, South Australia, Queensland, Northern Territory and Western Australia. ARF and RHD are more common in girls. Diagnosis. A prompt diagnosis of ARF is critical so that secondary prophylaxis can be commenced early to prevent further damage to the heart valves. For each episode, a final diagnosis should be reached and specified as definite ARF, probable ARF or possible ARF, and documented as an initial known episode or a recurrent episode. Suspected ARF is a term used until the diagnosis is confirmed or ruled out. There is no single test for ARF, therefore a combination of major and minor clinical manifestations with supporting laboratory evidence of a preceding strep A infection are required for diagnosis. For a first episode of definite ARF, a person must have 2 major manifestations plus evidence of a strep A infection, or 1 major and 2 minor manifestations plus evidence of a strep A infection. If a person has already had ARF, then the threshold for diagnosis of a recurrent episode is lowered slightly to include 3 minor manifestations plus evidence of a strep A infection. Due to the variety at which people can present with ARF and the lack of access to some tests, there are additional categories of possible and probable ARF. These are used when evidence of a strep A infection or one of the manifestations is missing and when there is no likely alternate diagnosis. The manifestations described here are based on people at high risk because they make up over 90% of ARF in Australia. Major manifestations. The most common is arthritis or arthralgia. Pain, redness and swelling usually occur in a large joint or joints and limits movement. The pain is classically migratory, transient and asymmetric and extremely intense. It can last from 2 days to 3 weeks in each joint. The description of pain can seem inconsistent and can easily be dismissed with pain relief if not better in a few days. The pain should be treated with paracetamol until a definitive diagnosis is made, because the symptoms can be masked by non-steroidal anti-inflammatory medication. The next most common major manifestation is sydenham chorea. This can occur months after the initial strep A infection, therefore it can be used alone to diagnose ARF. It appears as jerky, uncoordinated movements, especially affecting the hands, feet, tongue and face. Sydenham chorea is more common in adolescent girls and can be very distressing. It can affect one or both sides of the body and disappears during sleep. It usually resolves within 6 months and is strongly associated with carditis. Generally, no treatment is required, but if it is interfering with daily activities or resulting in self-harm, anticonvulsant medication can be effective. Rheumatic carditis refers to the inflammation of valvular endocardium. It is often asymptomatic. It can occur up to 2 to 6 weeks after other manifestations of ARF, so the correlation with acute rheumatic fever can be missed. It is important to perform a 12-lead electrocardiogram, an ECG, and organise an echocardiogram if ARF is suspected. Tip: the signs and symptoms of ARF do not necessarily occur at the same time. Skin manifestations. Erythema marginatum and subcutaneous nodules are both rare in Australia. Erythema marginatum is a rash, not itchy or painful, which occurs as circular patterns of bright pink macules or papules on the trunk and proximal extremities. It can be difficult to see on dark skin. Subcutaneous nodules are crops of small, round, painless nodules, often over the elbows, wrists, knees and ankles, that lasts for 1 to 2 weeks. They are rarely seen with ARF, but are highly specific for ARF and strongly associated with carditis. The minor manifestations may be more familiar to clinicians. A fever of 38 degrees C or higher can be transient. It often accompanies all manifestations except sydenham chorea. Monoarthralgia is a minor manifestation if joint pain hasn't been included as a major manifestation. A raised ESR, erythrocyte sedimentation rate, or CRP, C-reactive protein, and a prolonged PR interval on ECG counts as a minor manifestation if carditis is not included as a major manifestation. Evidence of a recent strep A infection is required to confirm a diagnosis of ARF. Blood serum can show 2 different antibodies, an ASO, anti-streptolysin O, anti-DNase B. These serum levels rise and fall at different rates, so more than one test may be required. The diagnosis of ARF requires a high level of suspicion. Any of these should trigger a red flag for ARF. Carditis, polyarthralgia or polyarthritis, sydenham chorea, erythema marginatum, subcutaneous nodules. A fever and ESR or CRP higher than 30, or a prolonged PR interval, or more advanced conduction abnormality. Tip: listen to the patient and the family when they describe their symptoms. The significance for diagnosis of ARF may not be immediately apparent. Actions required for all people suspected to have ARF. Arrange hospitalisation within 24 to 72 hours. Contact the specialist paediatrician, physician or cardiologist to expedite admission to hospital. An echocardiogram, an ECG, bloods including FBC, FBE, ESR, CRP, ASOT and anti-DNase B. Blood cultures if febrile. A throat or skin swab to culture for strep A before giving antibiotics. Use paracetamol for pain until diagnosis is confirmed. Contact the local RHD control program. Give benzathine benzylpenicillin to treat the strep A infection. Provide patient and family with culturally and age-appropriate education about ARF and RHD. Tip: find contact details for jurisdiction RHD control programs and access to key information on the free ARF and RHD Guideline and Diagnosis Calculator app. Download for free from Google Apps or the App Store.